denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivä töitä. Näin.
I'm an intensive care nurse, and I'm proud to work with a multidisciplinary team to work together to fight COVID-19. Together, we are intensive care medicine.
I'm an anaesthetist, and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm a primary intensivist, and I'm proud of it. We intensivists are working together side by side to fight COVID-19. Together, we are intensive care medicine.
I am an anesthesiologist, and I'm proud to be an intensivist. We intensivists working together to fight the COVID-19. Together, we are intensive care medicine.
I am a surgeon, and I'm proud to be an intensivist as well. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hello everyone, my name is Maurizio Cecconi. I'm the head of anesthesia and intensive care at Humanitas Research Hospital in Milan, and I am the president of the European Society of Intensive Care Medicine. It's a pleasure to chair this webinar today about the Surviving Sepsis Campaign COVID-19 guidelines that have just been released with Laura Galarza. Laura, she's a consultant in intensive care medicine at the Hospital General Universitario in Castellón in Spain. She's also the deputy chair of the next committee of ESICM. Before we start, let me tell you, it's a very important week for us in Europe with the European Society of Intensive Care Medicine. Just in a couple of days, we have a day that marks the anniversary of the crisis of COVID-19 in ICUs in Europe. It actually started very close here in Lombardy, where I work. Since the very beginning, with ESIC, we have tried to bring information and knowledge to everywhere in intensive care, to our global ICM community. One of the projects that we had for a few years now, for many years, joined with the Society of Critical Care Medicine in America, is the Surviving Sepsis Campaign. And the Surviving Sepsis Campaign allowed us to have a system of preparedness in this pandemic in a way that we could get all the evidence that was out there and to provide practical guidelines. There was a first guideline published last year, just at the beginning of the pandemic. What happened after was unprecedented, I would say, in the history of medicine, of intensive care medicine. A lot of research is going on. A lot of new evidence have emerged. And while in the community we now have the hope with vaccines, we know that we still have to fight probably for many more months in our intensive care units. So what we do with these guidelines is providing practical information for bedside clinicians. It's a pleasure today to have three of the leaders of these guidelines with us. And so I would like to introduce now the first speaker, Dr. Laura Evans. She is a director of critical care at University of Washington Medical Center in Seattle in the US. She's also the current SCCM Adult Guideline Co-Chair, and she's also a member of the SCCM Council. So welcome, Laura.
Thank you so much for the introduction and for the opportunity to be joining you. It's early morning here in Seattle in the US, and I'm delighted to be here. I want to take a moment just to echo what Maurizio was just saying in terms of the collaboration, I think, between the Society of Critical Care Medicine and the European Society of Intensive Care Medicine to form the Surviving Sepsis campaign many years ago really did lay the foundational work for the ability of the two societies and the Surviving Sepsis campaign to respond and hopefully help clinicians at the bedside take care of patients with COVID-19 during this unprecedented time. So it's a real pleasure to join you today. I do want to mention, just in terms of potential conflicts of interest, I am a member of the Surviving Sepsis Campaign Steering Committee. I'm on the Council of SCCM. I do co-chair the Adult Surviving Sepsis Campaign Sepsis Guidelines, and I'm the critical care team lead for the U.S. National Institute of Health COVID-19 Management Guidelines. I get the privilege this morning here in Seattle of kind of going through some of the background about the guidelines and the methodology of the guidelines, which you might start thinking it would be a little bit dry, but I think it's actually really important to understand the process of how we produce these guidelines so that you, as people taking care of patients, can help interpret the recommendations from these guidelines and how they may apply to the patients that you're seeing. I want to recognize all of the panel members who contributed to this update. As you can see, it's a large panel of really dedicated individuals from representing many, many parts of the world from that. I do want to particularly recognize both Andy Rhodes, who's the ESICM co-chair of this guidelines, and Walid Al-Hazani, who's the methodology chair. And Walid was really, I think, the driving force behind getting the initial publication of these guidelines last year out so quickly, as well as driving this update process, which has been a new endeavor for the Surviving Sepsis campaign to issue updates as partial updates. So I'm going to spend a few minutes, bear with me, on going through the methods of how we produce these guidelines. Again, I think it's really important to understand the methods behind it so that you can interpret what you might do with these guidelines. And as we go through the presentations today, I think you'll hear that there may be some minor differences between how the Surviving Sepsis campaign guidelines treat some therapies that might be slightly different than, for example, the WHO guidelines, or slightly different than the US NIH guidelines. And I think the methods, and then as we sort of go through what factors that the panel took into account to formulate a decision, this panel, this population of critically ill patients, inform the way that we interpret the evidence. So to get back to the guideline development process, we start with what's called a PICO question, which refers to a population, an intervention, control group, and the outcome. And so those are kind of what we determine to be the critical clinical questions that we're trying to issue guidance about. So we start with a PICO question, we then do a literature search, and we're looking for two things in this literature search. We're looking for either recent high-quality systematic reviews that would help us answer this question, or individual studies as well if there are not recent high-quality systematic reviews. Both of those lead us to summarize the evidence around a particular question. And I suspect this may come up in our discussion later, but certainly with the initial publication of these guidelines, there was not a lot of direct evidence about COVID-19. This was obviously a new virus to us. And so much of the evidence that we used to formulate the initial recommendations from the Surviving Sepsis Campaign COVID guidelines published last year was what we would call indirect evidence. So it was evidence that was based on other critical illness syndromes, so ARDS from other causes, for example. And we were applying that indirect evidence to COVID-19 to try to inform people's clinical practice at the bedside. So we start by summarizing the evidence, and that goes through this formal development of what we call an evidence profile, and it looks at the quality of the evidence in several well-defined areas. We then can upgrade the evidence based on the quality of the evidence, or we can downgrade the evidence if with the trials, for example, or there's significant concern of bias about the trials, or at the example I just mentioned, if the data was indirect, so if the trials were related to a different critical illness syndrome, but we think have some application, we may downgrade the quality of evidence or our level of certainty in how that evidence applies to this particular condition, COVID-19. We then go through a formal process called the evidence to decision framework. And I'll come back to that in a minute because I think that is important to understand the considerations that the panel went through to issue recommendations. The panel then discusses this. Sometimes that happens in person. Obviously, that did not happen with COVID-19 guidelines. We did this all virtually and over email, and people were up at all hours of the day and night to respond to this and really have robust discussions about the potential recommendations. We then formulate a recommendation, write the paper, send it to the journals for expedited review and publication, and now obviously we're in the dissemination phase of this, including webinars, website tools, infographics, and more. Conflict of interest management is an important part of any guideline development. And so in this guideline, we did not permit anyone with financial or industry-related conflicts of interest. We're not permitted to participate in the guideline panel. Intellectual conflict of interest or potential intellectual conflict of interest is a really important consideration because you really do want a guideline panel that is experts in the field. And often that means people who are doing the primary research or very involved in the clinical trials that may be informing guidelines recommendations. But I think many of you who have participated in clinical trials also know that being an investigator in a clinical trial may influence your thinking about that trial result. So we want those folks participating in the process because their voices are really important and they are truly the experts, but we also need to potentially manage that voice because if they are bringing any potential bias to the table about those trials, we need to manage that. So panel members who were involved in clinical trials relevant to recommendations were allowed to participate in discussions, but were not allowed to vote on the recommendations for which they had a potential intellectual conflict of interest. So let's go on through recommendations a little bit again, because I think it's important to understand this piece about how we can apply these to the bedside. And so anytime we're looking at a recommendation in general, we're trying to look at this balance between the potentially desirable consequences of an intervention and how does that balance with the undesirable consequences of an intervention. As we all know, everything we do in intensive care has potential risks and it has potential benefits. So you see the scale here in this example is highly weighted towards the desirable consequences as compared to the undesirable consequences. In this type of scenario, after going through this detailed evaluation of the quality of evidence, our level of certainty in the evidence, and then the evidence to decision tool, if we felt like the scale looked like this, where the desirable consequences far outweigh the undesirable consequences, we would issue a strong recommendation for the intervention. In contrast to that, I think what we see in our experience in critical care is often the scale is not quite as clear as that. We don't have that many interventions, unfortunately, where we see this balance of desirable consequences that far outweighs undesirable consequences. Often the scale is a little bit more balanced, or there's more uncertainty around that. So when you see a situation like this, we may issue a weak recommendation for the intervention. And in our guidelines language, from which we use grade methodology, you would see the distinction between those two. A strong recommendation would be reflected in a we recommend statement, and a weak recommendation would be recommended in a we suggest statement. So you can kind of feel that the language reflects both the strength of the recommendation and our certainty in the intervention. We can also obviously use that same context and same rubric to make strong recommendations or weak recommendations against an intervention. When we think about how we apply these guideline recommendations, we also want to think about the different populations that guidelines reflect or guidelines might be useful to. And so we'll start with patients, of course, because patients are at the center of what we do. So interpreting a strong recommendation in the context of patients generally means that for patients, most patients would want a recommended treatment or recommended intervention if it was a strong recommendation, and only a small proportion of patients would not want that recommendation. A suggestion or a weak recommendation from a patient perspective means probably the majority of patients in the situation would want that suggested intervention, but many would not. And so it sort of implies that you have to make a decision at the bedside as to whether you think this suggestion is both beneficial for this patient as well as aligned with that patient's values, preferences, and goals of care. When we go to clinicians and we think about how do we apply strong recommendations and weak recommendations, as a clinician, again, it means for us, a strong recommendation means for us that most patients should receive that intervention. It also means that we probably don't really need formal decision aids to help us decide for that patient, does this recommendation really apply to them? With regards to weak recommendations or suggestions, from our standpoint of a clinician of how we apply it, it means that different choices are probably appropriate for different patients. And again, it's all about context. It's all about what is this individual patient's circumstances, what are their values and preferences, and how do we best apply this recommendation to them. From a policymaker standpoint, this is probably a little bit less relevant to COVID-19 right now, although we might see this down the road. Strong recommendations can often be adapted to policy situations. And we see this in sepsis, of course, which is the use of strong recommendations for use as performance indicators. And that's a big component in the United States around using this for public reporting and reporting of performance in the hospital. Weak recommendations or suggestions may have less applicability to policies because your policy would be difficult to write, again, because it's all about the context and how do you apply that suggestion to an individual patient. So going back to this update, and Flavia and Marlise will go through each of the individual recommendations around this in a lot of detail. We had 4 original guideline sections in the guidelines published last year. They were testing and infection control, hemodynamics, ventilation, and therapeutics. And our first update, which has just come out, is really focused on the therapeutic aspect of these original guideline sections. We had 9 PICO questions addressed in this update, which led to 3 new recommendations and 6 updated recommendations. I want to spend just a moment talking about the guideline scope and definitions because, again, this might differ somewhat from other clinical practice guidelines that you might be looking at, whether that be the NIH, whether that be the WHO, whether that be other professional societies' guidelines. So we're using the WHO categories of severe COVID-19 and critical COVID-19 to inform the scope and definitions, as well as the context of our recommendations. So just to refresh your memories about that, severe COVID-19 would be clinical signs of pneumonia and at least one of the following: a respiratory rate greater than 30 breaths per minute, presence of severe respiratory distress, or the oxygen saturation less than 90% on room air. And critical COVID-19 would be defined by the presence of ARDS or respiratory failure requiring ventilation, or the presence of sepsis or septic shock. So I think we'll probably see these again later in the presentation. I just want to call your attention to a couple of the infographics that are available on the Surviving Sepsis Campaign website. And these are really meant to help be easy graphic tools that we can use at the bedside to help summarize many recommendations into an approach to patient care. So this reflects the summary of recommendations on the initial management of COVID-19 patients with hypoxia. And you can see the green check boxes are strong recommendations for an intervention. The red kind of do not enter signs are strong recommendations against an intervention. And the yellow or amber kind of exclamation points are weak recommendations or suggestions about considerations using the term consider in this infographic. And I'm not going to go through it in great detail. I just want to call your attention that these are available online, and we hope they're useful to you. And similarly, we have a summary of recommendations on the management of COVID-19 patients with ARDS with the same sort of context here. Green recommendations, green boxes are strong recommendations for an intervention. The yellow or amber is weak suggestions. and the red is don't do. So those are recommendations against an intervention. And here we have it separated into categories of COVID-19 with mild ARDS, COVID-19 with moderate to severe ARDS, and then rescue and adjunctive therapy. And I think probably surprising to nobody, our level of evidence, our assessment of the quality of evidence, and our level of certainty as we move through increasing severities of illness becomes less certain. And that probably doesn't surprise anybody who's listening to this. So with that, I'm going to pass it back to our moderators today. I hope you enjoy the presentation, and stay tuned for updates on supportive care from Dr. Flavia Machado and antiviral therapy and future directions from Dr. Marlies Osterman. Thank you again for the opportunity to be here today.
Thank you, Laura. And we are receiving a lot of questions through social media, so keep posting them. We will answer with everyone in the panel the questions at the end. So I'm going to ask my co-chair to introduce the next speaker now.
Thank you, Maurizio. So our next speaker is Flavia Machado. She's the head of the intensive care section of the anesthesiology, pain and intensive care department, and also a professor of intensive care at the Federal University of Sao Paulo in Brazil. She's a current surveillance campaign steering committee member for the European Society of Intensive Care. And I'm proud to say that it's the first time that someone from outside of Europe is part of the surveillance campaign from the European Society. And she's also part of the board member of the International Sepsis Forum. Thank you very much, Flavia, for being here today. And she will talk about supportive care, a proposition, and steroids and everything else. Thank you very much.
Thank you so much for inviting me for this webinar. It's a great pleasure to be here with Laura and with Marlies. And as Laura pointed out, our leaders on this process, they did a great job. And these updated guidelines are really quite helpful, I think. I will talk about supportive care. As Laura just mentioned, this is our board. They work very nicely. And these are my conflict of interest. I have to say that I'm very proud of being part of the executive committee for the Surviving Sepsis campaign on behalf of the European Society of Critical Care. Thank you very much for including me on this process. I'm really proud and of being part of this. And I have also to say, as a disclosure, that I'm a member of the executive committee for what we call COVID Coalition Brazil, which is a coalition among 8 institutions that are running trials on COVID in Brazil. Well, let's start with awake proning. We've been proning our patients, the intubated patients, for decades now. We aim to decompress the lungs, to aerate the lower lobes. We aim to decrease the weight of the heart in the lungs. We aim to reduce the mismatch between ventilation and perfusion. It all sounded so rational that this would help our patients. So we've been doing this, and we knew for a long time that proning patients improve oxygenation. But it took us many trials. It took us many years to find out in which patients this improved oxygenation will result in improved outcomes. And now we know that only in the sickest part of the ARDS patients, and only when you prone them for a long time, like 12, 16 hours, this maneuver can really result in an improvement in outcomes. So it's not easy just to say, let's prone our patients when they are awake, because this will help, because this is improving their oxygenation. This is not so easy to demonstrate. What evidence do we have? We run all the systematic reviews, and yes, there is some evidence. Here's the problem. It is a very low quality evidence. We have actually 35, all of them observational studies or case report studies about awake proning. and only 29 of them are in COVID patients. And among these 29, only 12 are prospective observational studies. So at this moment, this is the evidence that we have to analyze. And what we find out. First, okay, there is, this is the intubation rate, but there is no control group. This is the mortality, but in most of these studies, there are no control groups. There is one single observational study with a control group. But again, this is an observational study. And another problem is that most of these observational studies, they did not standardize for how long and with what frequency these patients would be in prone. So some of them were proning the patients for 1 hour in a day, and others were proning patients for 18 hours in a day. So this is another problem. And another problem is that some of these patients were in ICUs, so they were monitored. And another one, they were outside the ICU environment. So what we do know is that, yes, we have an improvement in the oxygenation in these studies, but another issue is that usually when you turn them supine again, you lose this improvement in oxygenation. And only one study did show that there was a sustained improvement, but only because the patients were put in non-invasive ventilation when they were supine again. Well, but if there is an improvement in oxygenation, why shouldn't we do this? It's so nice to see the patient involved in a self-care management of their health. This is a good thing about awake proning, and we actually don't know the benefits and patient-centered outcomes that can be gained on this self-management of their care. But we do have to think on the potential harmful effects, and we do nothing. We don't know nothing about this, because most of these observational studies, they did not report adverse events. Okay, some of them report about back pain, about intolerance on the positioning, about discomfort. But we do not know about important harmful potential effects such as delay intubation. We are all aware about the potential damage that we can have on delaying intubation because of the patient's self-inflicted lung injury. So having these patients in spontaneous ventilation might cause harm. So what we do have to think, as Laura said, is balancing what we know in desirable and undesirable effects. And the panel finally, after a lot of discussion, end up saying that at this moment, there is insufficient evidence to issue any recommendation about the use of awake proning position in patients that are not intubated. So this is an updated version of the guidelines, and we certainly are going to have other updates soon. And yes, we will have, I believe, new news on this, because there are lots of good and well-designed RCTs running in many places around the world. Just a quick check in clinical trials, and we can see many studies. These are 4 of them, good studies with an adequate sample size. That is another study run by BritNet in Brazil that is already finished. It's registered in the Brazilian website. So I believe that in a couple of months, we will start to see a good quality evidence about the safety and the potential benefit in clinical outcomes, and not only on oxygenation about proning position in awake patients. So let's go to the second point. The second point is corticosteroids. Differently from awake proning, because we did not address awake proning in the first version of the guidelines, here with the corticosteroids, we already have a recommendation. It was a weak recommendation about giving corticosteroids to the most severely ill patients. And this weak recommendation, as Laura mentioned, was based only in indirect evidence in studies coming from patients with ARDS, with viral pneumonia, but not in COVID patients. And this is the biggest change that we have now. So what was our equal question? It is if you're using or not corticosteroids, but we addressed only severe or critical COVID-19 patients in the ICU. This is an important point to make. We are not addressing corticosteroids in less severely ill patients. We are only talking about patients that are in the ICU with severe or critical COVID. So now, differently from the first version of the guidelines, we do have a lot of evidence, a lot of very good studies that were run in this meantime. And 7 of these studies actually were included in a meta-analysis that was run by WHO and published recently in JAMA. And they were also the base for a WHO recommendation that was published in BMG. And what can be depicted from the 7 RCTs? First, looking at the severe and the critically ill patients, what we see is a impressive treatment effect on these patients, as you can see here, both in mechanical ventilation patients, in invasive mechanical ventilation patients, and in all critically ill patients at 30%, around 30% mortality reduction, with the confidence intervals very adequate. So now we have a high quality of evidence for the critically ill patients and moderate quality of evidence for those patients in mechanical ventilation. So considering that there is a high quality of evidence, considering that the corticosteroids are widely available and not expensive, the panel decided to issue a strong recommendation for the use of a short course of systemic corticosteroids over, of course, not using any corticosteroids with a moderate quality of evidence. So this was the easiest part of this recommendation. The second part was not so easy because it's more controversial. And it was which corticosteroids should we use? Because these studies, they use different corticosteroids. 3 of them, including Recovery, which is the biggest one, and Codex, the Brazilian study that is the second biggest one, use dexamethasone. 3 studies use hydrocortisone. 3 studies use hydrocortisone, and 2 of them, there is a study that was not included in the JAMA meta-analysis. This is not a Brazilian study, used methylprednisolone. And if you look at here in the effect size, it is clear that the dexamethasone has the best effect size of all the 3 types of corticosteroids, and also the best confidence intervals. The confidence intervals for hydrocortisone crosses the 1, and the confidence intervals for methylprednisolone, it's not a good one. So there were arguments saying that the other studies, they were all stopped by the investigators or by the DSMB when the recovery trial launched their results, because of the benefit found in the recovery. And the early interruption of these studies might have caused these larger confidence intervals. However, we think that this effect size plus this confidence interval was enough to base at least, to base at least a weak recommendation for the preferential use of dexamethasone over the other corticosteroids. And this is based on very low quality of evidence, as we do not have any direct comparison between the 3 types of corticosteroids that have been already used in COVID patient studies. So it's a weak recommendation, just a suggestion. And of course, we are aware that although widely available, dexamethasone might not be available in some parts of the world. So there is also a remark saying that if dexamethasone is not available, clinicians certainly can use other corticosteroids in equivalent doses of the dose of dexamethasone that has been used in the recovery trial, which was 6 milligrams of dexamethasone for up to 10 days. Which leads us to another problem, which is the dose, because as you say, we are recommending as a suggestion that we use 6 milligrams. Let's see why. This is the figure coming from the JAMA meta-analysis. And as you can see, this is the dose used by recovery. And the doses used by Codex and Dexa COVID-19 were much higher. Both trials used 20 milligrams of dexamethasone. The trials using hydrocortisone, they use a similar doses of recovery. So we thought there was enough evidence to recommend the dose used by recovery. However, we also have to consider that recovery included different patients, included other patients that is not, of course, here we are analyzing only the severely ill patients and the patients that are severe or critically ill. But there is a lot of discussion running now about doses and about duration, because we are all aware that these patients are, some of these patients are complicated with organizing pneumonia, which lead us to what's next. So we need new trials, that is for sure, and there are some trials already running. There is a trial running to compare 6 milligrams with 12 milligrams. There's a new trial started in Brazil with low dose and higher dose. So this is an unanswered question that we will need to seek for. How early should we start corticosteroids? What is the best duration of treatment? Is it only 10 days? We need to know better. We need new trials to answer this question. And there is also some discussion about which is the best corticosteroids to use when we do have, together with COVID, ARDS, septic shock. So certainly we will have a lot of discussion and hopefully good new trials for the next updated version of the Surviving Sepsis Campaign COVID guidelines. And last but not least, VTE prophylaxis and anticoagulation, the burning question at the moment. We all know that the severe forms of COVID resembles and is sepsis, and we all knew for a long, long time that sepsis caused microthrombosis, and we have tried for years and many, many drugs to find a way to control the microthrombosis in sepsis using different drugs, different types of approach. But now with COVID, there is something different. Yes, we do have the microthrombosis, but we also have more arterial thrombosis, and we also have more venous thrombosis. So it is a huge challenge how to face this. And there's a lot of confusion on this. There is a lot of people just using anticoagulation. There is a lot of people using a intermediate prophylactic doses for those patients. So it's another huge discussion. So the first thing we did in the board was to try to address a simple question. In patients that are in the ICU with severe or critical COVID, should we recommend using VTE prophylaxis versus no prophylaxis? Seems to be pretty obvious, but sometimes the obvious things needs to be said. So when you look at this question, comparing thromboprophylaxis with no prophylaxis, we do not have any data regarding COVID. So what we have to look at was, again, for indirect evidence. coming from critically ill patients as a whole. And we found systematic reviews comprising 4 very good randomized trials. And these trials shows clearly that there is a reduction in the risk of deep venous thrombosis, a reduction in pulmonary embolism when we do prophylaxis in these patients. There is a moderate quality of evidence for DVT. There is a high quality of evidence for pulmonary embolism. And yes, it seems not so convincing that these patients having prophylaxis has a higher risk of bleeding and no change in mortality. But we think that, yes, there is enough evidence to show and to base us to recommend that we should treat COVID patients as we treat the other critically ill patients, or which means using pharmacological venous thromboprophylaxis over not using this. So this is not a burning question. The burning question is this one. So if you have a patient in your ICU that has COVID, severe or critical COVID, and this patient has no confirmed VTE, should we recommend empiric anticoagulation versus prophylaxis? This is the burning question. And as I said, there's a lot of discussion about this. We have a systematic review showing that this COVID patient population, they have, of course, a high frequency of VTE, and they have 26% in average events, venous thrombosis events. So, of course, it's worrisome if you have to do anticoagulation, empiric anticoagulation. And there's a lot of discussion if D-dimer is a good marker or not. So those patients with elevated D-dimers should receive or not anticoagulation. It is a good marker. Can we predict that those patients will have a complication if their D-dimer is elevated? The answer at this moment, with the available published data that we had at that time and we have at now, it's we don't know. We don't know because there is no data. There is only, or there was only, pre-observational studies, and these observational studies are from, of course, very low quality of evidence, and they show, okay, that maybe there is a difference in mortality, maybe there is a difference in pulmonary embolism, but what we discuss in the group is that as the risk of bleeding is certainly higher in patients receiving therapeutic anticoagulation, it's higher versus those patients receiving only prophylaxis, and in complete absence of proven benefit, the panel decided to issue a recommendation, a suggestion against the use, or at least the routine use, of therapeutic anticoagulation. And this is the important part of the wording of this recommendation, outside of clinical trials, recognizing that this is an important question to be answered, and that we have to include patients in clinical trials, and there are many clinical trials all over the world trying to answer this. Well, after the publication of the guidelines, and I think that many of the people that are listening to us are aware of this, we have this the release on January 28th of this interim analysis of this multi-platform RCT. This is an amazing initiative of the investigators from the 3 platforms, the ATAC, Active4, and the REMAP-CAP. They have run in conjunction the trial to analyze exactly this question, if we should or not anticoagulate patients. This is, and they made it very clear that what they release, it is a publication coming from a non-locked database, which means the data is not cleaned. They have still to clean the data. And of course, this is a non-peer-reviewed data. But they have the world known that the 3 trials were stopped at the same time because they have an agreement about this for different reasons. And I think that we might have the opportunity to discuss this during the question and answer at the end. So they have 2 different groups in this platform trial. They have the severe patients. Severe patients for this trial are those patients admitted in the ICU and receiving organ support, which means high flow nasal oxygen, non-invasive or invasive mechanical ventilation, or requiring vasopressors inotropics. And they finished the inclusion because the data safety and monitor board advised them to discontinue enrolling patients because of futility. They were not able to show differences. And there was also an interim conclusion suggesting that probably therapeutic heparin was inferior to the thromboprophylaxis. And there was a numeric, not statistically significant, increase in major bleeding events and in mortality in the patients receiving therapeutic heparin. By contrary, in the less severe group, the moderate patients, the trial was also later interrupted, but now they interrupted the trial because the pre-specified superiority boundary was reached, suggesting that there was a superiority in the treatment and the therapeutic heparin. And there is also a suggestion that it was achieved, this superiority was regardless the D-dimer strata. They have a D-dimer, normal D-dimer, elevated D-dimer, and unknown D-dimer strata. And well, this trial was stopped. It is unpublished. It's not peer-reviewed, and we will have to wait to publish our results. And certainly, in the next updated of the Surviving Sepsis Guidelines, the published paper will be considered for sure. And of course, also the other results for other trials that are now currently enrolling patients. So thank you very much, and I'm happy to take questions at the end.
Thank you very much, Flavia. It was an amazing presentation. Please keep sending all your questions. I'm sure the presenters will answer all of them. And now I will send it back to you, Maurizio, so you could introduce Marlies.
Thank you, Laura. And so last but not least, Dr. Marlies Osterman. She's a consultant in intensive care medicine and nephrology at Guy's and St. Thomas's Hospital in London in the UK. She is the current deputy chair of the adult guideline for the Surviving Sepsis campaign for ESICM, also the current chair of the acute kidney injury section, the course director of the Society Renal Replacement Therapy state-of-the-art masterclass. Marlies, the floor is yours.
Thank you very much. It's a great honor to contribute to the guideline, and it's a great honor to share some thoughts here at this webinar together with very eminent people. In the next 15 minutes, I will talk about the role of hydroxychloroquine, remdesivir, and convalescent plasma. These are my disclosures. They did not affect my contribution to the guideline, and they have not influenced this presentation. I would like to admit that some of the slides which I will present were actually at the courtesy of Professor Laura Evans, and I'm very grateful to her. As Laura already said, throughout the document and throughout this presentation, we will talk about severe COVID-19 and critical COVID-19. And both conditions are defined according to the criteria set by the WHO, as Laura outlined earlier. Starting with hydroxychloroquine. So this is a drug with in vitro data suggesting that it can inhibit SARS-CoV-2 replication. So at first glance, it appears very appealing. In the first issue of this guideline, no recommendation could be made because there were not enough data available. But since then, at least 5 new randomized controlled trials have been published, and therefore it was important for the panel to issue a guideline. The panel addressed the question, should we recommend using hydroxychloroquine versus not using hydroxychloroquine in adults with either severe or critical COVID-19? The outcomes of interest were mortality, or requiring mechanical ventilation, or development of adverse events. 3 studies reported mortality at either 28 or 30 days. And as you can see here on the right, there was a signal towards harm in the hydroxychloroquine group, better outcomes in the group randomized to control, not receiving hydroxychloroquine. If we look at the development of adverse events, there was a clear sign of more adverse events in the hydroxychloroquine group, or the other way around, less adverse events in the control group. This is repeatedly shown here in the evidence table, and if you look at the top, you will see that when we look at mortality, there was a trend, a clear trend towards lower mortality in patients who had not received hydroxychloroquine. And if you look at the bottom line and look at adverse events, there were clearly more adverse events in patients randomized to hydroxychloroquine. So in conclusion, having looked at all the data, the methodologists concluded that the use of hydroxychloroquine in hospitalized patients with COVID-19 did not reduce 28-day mortality, did not reduce the need for invasive ventilation, but did increase the risk of adverse events. And based on this conclusion, the panel recommended against using hydroxychloroquine in adults with either severe or critical COVID-19. The next therapeutic agent was convalescent plasma. And clearly, again, this is a very exciting area because previous observational data from other types of acute respiratory illnesses or viral etiology had suggested an association between passive immunotherapy with plasma and a reduction in mortality. When the previous issue of the guideline was drafted and published, no recommendation could be made because there was not enough data available related to COVID-19. But since then, more data has become available in the form of at least 4 new randomized controlled trials. And at the time of the development of the update, these 4 new randomized controlled trials were analyzed. They included a total of 732 patients. So the panel addressed the question, for adults with severe or critical COVID-19, should we recommend using convalescent plasma versus not using convalescent plasma? Again, outcomes of interest were mortality and development of adverse events. All 4 studies reported mortality data. And as you can see here, there was no clear evidence that either therapy was superior. The risk ratio was 0.77 with a confidence interval between 0.48 and 1.24. The trials did not really report any adverse events, specifically to plasma. So based on the data, the panel suggested against the use of convalescent plasma outside a clinical trial. As demonstrated here at the bottom, there was not 100% consensus. About 1 in 6 panel members felt that it was too early to issue a recommendation. Since the publication of this particular recommendation, more data has become available, which is in line with the updated guideline. We have data from the plasma study published at the end of November last year, which was a randomized, controlled, multi-center trial in 333 adult patients hospitalized with COVID-19 pneumonia. And the trial concluded that there was no significant difference in clinical status or overall mortality between the two arms. Last month, the investigators of the recovery trial stopped recruitment to the plasma arm. As demonstrated here, a preliminary analysis had shown that there was no significant difference in 28-day mortality between the convalescent plasma arm and the usual care arm. And based on this preliminary analysis, further recruitment to the recovery arm, to this particular convalescent plasma arm of the recovery trial, was ceased, showing that the guideline as it was issued by the Guidelines Committee is in line with subsequent new data. Clearly, this is a moving field where new data quickly become available, but the recommendation as it was issued by the panel is consistent with subsequent data. Lastly, Remdesivir is also obviously of interest, given that it's an antiviral medication. It's a prodrug of adenosine analog, which can inhibit the replication of coronaviruses. This has been shown in in vitro studies and also in non-human primate models. The previous issue of the guideline did not have any recommendation due to lack of data, but more data have become available from various different studies, some comparing Remdesivir with placebo and others which include a Remdesivir as part of a platform design. The panel looked at Remdesivir in patients with severe COVID versus critical COVID separately. And the first question was, in adults with severe COVID-19, should we recommend using Remdesivir versus not using Remdesivir? Outcomes of interest, again, were mortality and onset of adverse events. And in this group of patients with severe COVID-19, who are defined by not needing invasive mechanical ventilation or having sepsis or septic shock, there was a signal towards lower mortality. And therefore, the panel suggested using intravenous Remdesivir in this group of patients, i.e. patients with severe COVID-19 who do not require mechanical ventilation. The panel added a comment, and based on the data from the ACTT1 trial, it was clear that Remdesivir seemed to be most effective if used early, i.e. within 72 hours of a positive PCR or antigen test. This next group to look at was the patients with critical COVID-19. And these are patients characterized by either needing mechanical ventilation or having sepsis or septic shock. Again, the question was, in adults with critical COVID-19, should we recommend using Remdesivir versus not using Remdesivir? And as you can see here, if you look at mortality at 28 days, there was no clear difference between the two groups. Using Remdesivir did not result in a significant difference in mortality compared to not using Remdesivir. And therefore, the panel suggested against the use of intravenous Remdesivir in this particular patient group, i.e. patients undergoing mechanical ventilation for COVID-19. It should be remembered that Remdesivir is clearly still remains a bit controversial in that not all studies showed a clear benefit. There was no clear harm, but the existing data included in this guideline were of low to moderate quality. And it should also be acknowledged that this is a medication associated with costs, which is not always available in all parts of the world. And we may see more data from larger studies which are still either ongoing or under in the analysis phase. In conclusion, this is clearly a moving field. This is a dynamic guideline where the data and the recommendation are based on data as the data become available. There are still a lot of large randomized controlled trials going on at the moment, and more data will clearly become available related to the use of tocilizumab, aspirin, colchicine, monoclonal antibodies, and so forth. We will also get more data about potential combination therapy, because it appears that some drugs may work better or less well in combination with others. And all of this will become clearer as the platform trials get analyzed. And lastly, I think a lot of people have noticed and reported a change in the patient population and in the change in the phenotype. And the phenotype who we looked after and cared for in the first wave appears to be different in the second or third wave. A lot of colleagues have reported seeing more barotrauma in the second wave. And others have reported more infections, more hospital-acquired infections. Whether this is related to mutations of the virus, changes related to the genetic profile of the virus itself, or whether it's related to the treatment, in particular the initial treatment, the use of steroids or the use of different fluid management strategies, is unknown at the moment. And so any future guideline will have to take this into account and may also have to include new topics which were not immediately clear in the first instance and in the first wave. For instance, how to prevent barotrauma. And with that, I'd like to finish and really thank everybody involved, in particular, obviously, the panel and the methodologists who did an amazing work in putting the data together, collecting the data and analyzing it at rapid speed. I'd like to thank the European Society of Intensive Care Medicine and the Society of Critical Care Medicine for sponsoring this and for their leadership. And ultimately, I'd really like to thank people who are either caring for patients with COVID or making the data available, the research teams and all the colleagues around the world caring for patients. Thank you very much.
Thank you, Marlies, for a wonderful presentation. Great to have all the panel back together now. We have a few minutes of questions, and we are receiving a lot of questions through social media. Maybe I'm starting with one question, which I think is very important. We have received a question about low and middle income countries. They've been particularly affected by this. How do the guidelines can reflect the practice there? How can they be implemented there? But to start even before, how was the panel put up in a way that is also representing low and middle income countries? Maybe Laura Evans, do you want to start with an answer?
Sure, I'll start and then ask Flavia and Marlies to weigh in as well. So I think you already raised the critical point, which is that guidelines that reflect practice around the world require representation in the panel that's developing the guidance from people around the world. And that has been an emphasis that we've tried to focus on within the Surviving Sepsis campaign over the last both sepsis guideline revision as well as in the composition of this panel in making sure that we have an inclusive panel that represents people around the world. We're still challenged, honestly, that the bulk of the evidence comes from higher resource countries because of the clinical research infrastructure. But I think efforts like the Solidarity trial from the WHO are wonderful examples of doing clinical research in a variety of resource settings that really help us issue guidance that reflects practice around the world. In terms of how the recommendations can reflect different resource settings, I think some of the evidence to decision tool pieces that we talked about and that Flavia and Marlies explained in terms of contextualizing some of our recommendations do take into account some resources. So we talk about, what is the effect of a recommendation or an intervention on equity? So in terms, is there variable access to this treatment? What is the cost of this treatment? And all of that goes into our assessment of the desirable and undesirable consequences of an intervention, but it's very much a work in progress. So let me stop there and see what Flavia and Marlies want to add to that.
Well, I fully agree with everything that Laura says. The Surviving Sepsis campaign, both COVID and non-COVID, has improved a lot in the last years. And I've been part of this, and I'm seeing this improving, and we are taking into account low and middle income countries, certainly. And I would say that COVID was an opportunity to have more data actually coming, not from low-income countries, because this is still very hard, but at least from middle-income countries. So we have data coming from India, from Brazil, and it is important because we have different settings, we have different environments. We are discussing tocilizumab, for instance, and we will have conflicting results. And this might be different, for instance, when you have high rates of nosocomial infections, and using dexamethasone with tocilizumab may be different when you have different rates of nosocomial infection. So we will have to contextualize now and even more in the future how these interventions might affect differently different parts of the world. But for this update version, let's look at it. Awake, Prony, you can do everywhere. Heparin, you can do everywhere. Dexamethasone or any other corticosteroids is available everywhere. So, okay, Remdesivir, it's not available everywhere. But convalescent plasma, it's expensive, yes. So, but hydroxychloroquine we're not using, so it doesn't matter. But what I'm trying to say is we are focusing in treatment that maybe are more cheap and more available than in the past. So I see it as a problem for sure.
And if I can, before I ask Marlies also her opinion on this, I would like also to make a point that this pandemic has given an opportunity also to learn from low and middle income countries more than before, because you mentioned Brazil. I have to say, the amount of evidence that you have been providing in Brazil has been extraordinary. Valuable for improving care worldwide. So it's not a kind of a unilateral approach, which I don't think can work for the future, as being a bilateral approach of sharing evidence. And I think that's something we need to bring with us for the future as well. Marlies, what's your take on this?
No, I fully agree with what you've said. We've learned so much from all the panel members from different countries. What I do hope is that this is also an opportunity to help the lower and middle income countries. Because if we can say that the standard of care is a combination of two or three things or four things, then hopefully societies and the WHO and we all will help making this available to everybody, including low and middle income countries. And I think that's our responsibility as well. But we not only discover or develop guidelines, but also then feel responsible and make sure that everybody has access and it's equitable.
Yeah, I completely agree. Laura Galarza, do you want to get the next question?
Sure. I'm going to change a little bit the topic. And since the beginning of this COVID pandemic, we have received many guidelines from everywhere, and some of them are really confusing because giving some mixed messages, and it's getting our practical work sometimes a little bit difficult. For instance, if we talk about anticoagulation, Flavia, I'm gonna give it to you, this question. For instance, a German guideline says us that we should anticoagulate every patient in critical care, and also some patients in the normal wards if they have some risk factors. But also some other guidelines from the UK says us that we should administer some intermediate dose of heparin in patients in non-invasive mechanical ventilation. And can you give us some peace of mind, please? Because, I mean, we are really confused.
Yeah, I think that it's not our listeners that are confused. We all are confused because we don't have evidence. So when we don't have evidence, we have to use the best evidence available. And when we only have observational studies, some of these guidelines group, they can use expert opinion. And when you go to expert opinion, the experts can have the opinion they want to have. So that's the point. When you have differences in guidelines, I would say that people have to carefully read what they are using as evidence. Because if it's expert opinion, it is just expert opinion. So what I'm trying to say is that when you look at the evidence, the correct answer is we do not know. We do not know what you have to do with the COVID patients regarding anticoagulation. And it is true that they have an enhanced coagulation. It is true that the dimers are markers of this enhanced coagulation. It is true that there is an association with high levels of the dimers and poor prognosis. But we do not know if treating them will lead to better outcomes, because treating them will put them at the risk of a higher, will put them at a higher risk of bleeding. So it will treat the coagulation issue, but will put them in higher risk of bleeding. And the only way to answer which are going to be the balance of harmful effects and beneficial effects is a randomized clinical trial. And we will have to wait. And we already know, and we have to wait for the published study, that at least the interim analysis of this 3 Marvelous multi-platform trial are showing us that at the moderate cases, it seems that anticoagulation is beneficial because probably the harmful effects of the higher risk of bleeding, it's small. But at the severely ill patients, our patients, critically ill patients with ARDS and shocked patients, the risk of bleeding, it's higher than the beneficial effects of anticoagulation. So at least in a preprint, a release of this wonderful study, it seems that the harmful effects for the more severe ill patients, it's showing us that we should not. But let's see the evidence. We don't know.
So if I can elaborate on that, I think what we've learned in this pandemic is how important trials have been, not only to find about a drug usefulness, but in the face of the disease. There was so much confusion about steroids, and we now know that steroids should be given, but probably when you start to have the necessity of being in oxygen, giving steroids at home probably would be dangerous for patients. And in this sense, with all the trials coming out, can I ask a more of a personal question, maybe starting with Marlies, still as a physician? With these guidelines, we try to bring all the evidence together with experts, and we try to digest this evidence and to come with some recommendations. But you, in your daily practice, when do you change your practice based on a preprint, based on some of the releases that we've seen so often recently? In the specific And there has been recently a release about tocilizumab, which is not out yet, but the preprint where everyone is being able to see. Did you change your practice in the UK, in your hospital, based on that? Maybe you can give me some other examples, Marlies.
Thanks, Maurizio. I think we're addressing a really important issue here, which is that it refers to what you said in the beginning, that we are dealing with an illness which we've known for less than a year. It's still a baby. For the first time, all of us are in a situation where we have a new disease we knew nothing about. It didn't appear in our text, isn't in our textbooks. We all come to work to do good. We want to do the best, and we face the fact that there's so many uncertainties, and that what we did 3 months ago in good faith may no longer be best evidence, and we may have to accept that it could have potentially been harmful. So with that in mind, in our hospital, we have rapidly developed guidelines for the department, and quite a few of them have changed significantly in the last year. What do we base this on? We started with guidelines in the beginning just to give everybody some guidance, which was based on the existing recommendations. So in communication with you, your colleagues in Milan, colleagues in the US, and colleagues in China. And then as new evidence from published data became available, we changed guidelines. We didn't change based on preprints. And very recently, we changed the guideline based on advice from the Department of Health. So in the UK, the Chief Medical Officer, the Department of Health, issued a recommendation related to tocilizumab last week. And in response, the guideline is being changed. So we're doing this in response either to published peer-reviewed data or official mandates, guidance, probably from the Department of Health. And we have to accept that things still change, and things we did 6 months ago may no longer be the right thing.
Okay. Can I add on that for a minute? Because I think it's been such an interesting time period, right? The rapidity of information coming out, the use of preprints and press releases. And we've never seen the pace of anything like this. And then it's been paired with, I think, this intense sense of clinical urgency at the bedside because of the flood and the numbers of patients and how sick they are. And so I think people at the bedside have felt this incredibly intense pressure to do something, right? Just based on the basis of what they've been faced with in their day-to-day professional lives. And I think it's been an interesting opportunity to reflect on what our own individual thresholds are for change, as well as I think an opportunity to reflect on critical care research going back. And, have we been burned before? If you think back to activated protein C, and its use in sepsis, right? That we had some positive trials and we thought we had a therapy, and then we didn't corroborate that in subsequent trials. And so I think there's a note of caution to be introduced into it as well. And I think for me, my individual threshold, I think, to change is a little bit more based on, in a preprint, in a press release, is there signal of harm associated with an intervention? Because I think our supportive care treatments, we have a good sense of what the balance of benefits and harms are. But these interventions do have potential harms with them. And I think I'm a little bit, my bar to be convinced that something hurts people is probably a little bit lower than my bar to be convinced that it helps people.
Fear to no harm, I think, is being one of the biggest learning in the recent months, taking down probably some of the drugs that were used without evidence at the beginning. I agree with that. I think we're running short of time, but I think Laura, my co-chair, probably would like to ask one last question.
Chair, I will ask one last question. Maybe for Laura, but everyone can join in. When will you will update these guidelines? Because we are seeing now probably some good studies will be released soon. So maybe 6 months or a year.
I hope a lot sooner. Yeah, Flavia and Marlies both beautifully addressed some of the ongoing, really urgent clinical questions of anticoagulation, and now, of course, what to do with the IL-6 inhibition, blockade agents. And clearly, those are the questions that people have when they're taking care of patients at the bedside. So we have not incorporated, we have not changed recommendations based on preprints or press releases from that, but we are actively in discussions with the leaders of the guidelines panel and the panelists to prepare new and updated recommendations. And so I don't have a date for you, but hopefully pretty soon.
Okay, I take it.
I can't give you any spoilers.
I think we should add that clearly we all want up-to-date guidelines at all the time. And it is an honor and also really fun to go through the data and formulate some discussions and hear everybody's view. But it's also a lot of work, and we have to recognize that the methodologists and the librarians have done an amazing job in keeping up to date and grading and analyzing the data, which means it will also take time to get an update. And we would like it, as I'm sure, as quickly as we can, but that means a lot of work for people in the background who at the moment get the recognition.
It looks like a continuous process because we are having these releases of huge trials so fast. We have never seen this before in the critical care. So now we just have this toxi data and the heparin data. So we have to start doing this. And when we finish, there is going to be another trial on heparin. And so it's just a ongoing, non-stop thing. So we are just missing the normal surviving sepsis campaign, which is every 4 years, Laura.
But it is exciting how much we've learned. It's very exciting.
Thank you very much for being here. I'm gonna give a little wrap up. Thank you all for being here. Mostly Flavia and Laura. It'd be a little bit out of hours for you. But thank you for being here, and also Marlies, you were wonderful, the three of you, and my co-chair Maurizio. As always, it's a pleasure being here with you. I'm really sorry we don't have time to ask you more questions. There were a lot of questions from people, so I will encourage them to ask all of you questions over Twitter. We have posted many things in the Instagram, Twitter, and everywhere, so they can keep in touch with you and ask all the questions. Maurizio, if you want to say something else, if not...
Thank you very much. It's been fantastic, and I really enjoyed. Thank you for everything that you're doing and for today. And everyone, really keep posting questions. We will try to give you an answer. Maybe we'll pass them to the panelists later on.
Thank you.
Thanks so much.
Thank you for inviting us.